This is the CT scan of a patient who already underwent bilateral endoscopic sinus surgery 2 years back and has now presented with recurrent symptoms. And as we can see, the frontal sinus anatomy here is distorted due to the presence of an isolated cell, or which could also be most likely a suprabular ethmoidal cell, which has to be seen on a sagittal cut. One can see patchy opacification in the anterior ethmoids, occlusion of the osteomeatal recesses, as well as you can see here, the presence of a type 2 cell, type 2 or type 3 cone cell anteriorly, and over which one can see pneumatization of a frontobular cell, which pneumatizes right inside the frontal sinus, which can often be confused as a isolated frontal sinus cell, which mostly is a frontal bular cell. And that is because the posterior wall of the frontal bular cell happens to be the skull base itself, unlike the cone cells where there is a distinct posterior wall of frontal sinus behind the cone cells. As you can see some polypoidal tissue, some scar tissue in both the middle metasis in this patient, since it is a revision surgery. And as always, all the possible causes of revision must be addressed if we are to avoid further recurrence in this patient. So we begin by identifying the antrostomy, ensuring that it is wide enough for not just irrigation, but also for adequate identification of the landmarks. So as we can see now, a lot of scar tissue or some polyps obliterates our ethmoid sinuses, which again need to be clear. So following the antrostomy and the vertical and the horizontal antrostomy ridge, we take our shaver blade posteriorly to create the opening inside the ethmoid sinuses. And just like the other causes of revision, removing all the possible causes of failure, such as any remnants of the uncinate process, opening of the frontal recess, removal of all the ethmoidal septations, wide opening of the sphenoid, and management of any possible issues like deviated septum are very important to ensure the eventual success of this second surgery. So here we're just using a navigation probe to orient ourselves to locate the lamina papyracea in this patient, the ethmoids, and just to see that there should not be any tracking error before we get to the more important and critical cases. So as we had remarked on the CT, the sphenoid was more or less clear. However, there was opacification and disease in the ethmoids, both anterior and posterior. That would need to be clear. Even here one can see reasonably patent sphenoid sinus behind and some polypoidal and scar tissue in the ethmoid sinuses. So here we see that our probe immediately points towards the lowest most part of the skull base at the sphenoid, and we can track going from posterior to anterior following the possible trajectory of the skull base, though right now the skull base is not visible to us. The axilla of the middle turbinate is a very important landmark when it comes to locating the frontal recess and eventually the frontal sinus ostium. As we see here, the sphenoid os is already been opened, and that happens to be a very important landmark to identify the lowest most point of skull base. Since it is already open, we just can increase the size of the sphenoid os widely so that it does not again cicatrize and lead to any stenosis. So any soft tissue can be managed very well by the shaver blade, whereas any bone must normally be removed using either bone punches or straight mushroom forceps to create a wide sphenoid opening. Because in revision surgeries, normally one would not like to take a chance, and we want to create as clear and straightforward a corridor for generous irrigation in the post-operative period by the patient to be able to achieve adequate outcomes. So once we have done the soft tissue work with the microdebridor, we can resort to the straight bone punch to remove some bone and widen the sphenoid os. This can be done medially, this can be done inferiorly and laterally, just to be taken care not to go too inferiorly, because then that would jeopardize the sphenopalatine artery, the septal branch, which would lead to unnecessary bleeding and wastage of time in the surgery. Now, as we see here, the sphenoid has been opened on the left side, happens to be quite clear, and one can see how the ethmoid septations still remain after the first surgery, which would need to be clear for us to be giving this patient sort of a canal wall down kind of an approach that we take in ear surgeries to create a very wide area for both examination and irrigation. So here we use the bone punch. We keep palpating the level, the amount of bone that is left to be removed, and we keep using the bone punch to remove more bone towards the, to clear off the septation between the posterior ethmoid and the sphenoid sinus superiorly. Sharp cutting forceps and sharp cutting bone punches are very vital, so that one has minimal amount of mucosal avulsion, because then that leads to generally exposed bone and scarring. And some excess tissue or mucosa that does become avulsed can be transected using good quality true cuts rather than using a Blacksley forceps, which would simply avulse the mucosa and would lead to poorer outcomes in the long term. I once again say that one must attempt completely to remove all the possible causes of failure, usual failure in sinus surgery, though one cannot ensure that there would be no recurrence, because the polyp disease itself has a propensity to recur. But at least the surgical causes of recurrence, the known causes, can be addressed and have to be addressed in all revision surgeries to be sure that from a surgical standpoint, there are no stones left. So here we still clear some more bone to create a wide straight corridor for irrigation, that the irrigation fluid reaches the sphenoid sinus very, very easily and appropriately. And also that would help us see our superior limit, and we could see the superior limit of the sphenoid, and we could then move forwards and anteriorly towards the posterior ethmoids. Once again, any excess mucosa that incidentally or accidentally gets slightly avulsed should be trimmed using either a shaver blade or using a straight true cut forceps. Once again, time to time, we keep using the navigator probe to make sure that we have minimal tracking errors, that once we come to the more important parts, the tracker does not overshoot or undershoot. As you see here, we are normally not very keen to remove the middle turbinate in revision surgeries, because this does act as a very important landmark for us throughout the surgery in navigating our way towards the ethmoids as well as the frontal sinus region. Here we are using a straight suction navigator, an angled frontal sinus suction navigator, to make our way inside the frontal recess, though not the frontal sinus itself right now, because as we had seen, the anatomy of the frontal sinus is slightly distorted here by the presence of both a T2 or a T3 cell, Kuhn cell anteriorly, as well as the presence of a large frontal bular cell that rides nearly over it, restricting thus the frontal sinus opening. Here once again we are tracking our most important landmarks which we use throughout the surgery, such as the superior wall of the maxillary sinus, or the horizontal antrosome ridge which points towards the sphenoid, and the transitional antrosome ridge which points towards the posterior ethmoids. And now to be able to conclusively see inside the frontal recess, as you see here, a curved instrument does go inside the recess, but not quite the sinus. And we have to increase the anterior exposure by removing the anterior wall of the agar nasi using a bone punch first to be able to see more conclusively using a 0-degree endoscope. Till we do that, we nearly are in the blind, and we can work by the palpatory method, but not through the inspection. So here we use a straight bone punch initially to remove some portion of the anterior wall of the agar nasi so that our vision inside the frontal recess becomes better with a 0-degree scope. Now we resort to a frontal sinus curette to clear more bone anteriorly, to fracture the posterior wall of the agar nasi as well, and to any remnant cells in the frontal recess that still occlude our access. So one should remember that since the dissecting from posterior to anterior in the frontal recess area is a very safe method, because one avoids the skull base here, which lies just posterior to the posterior table of the frontal sinus and posterior to the frontal recess, being the cribriform plate. So any work that one does posterior to anterior generally can be considered quite safe in terms of skeletonizing the frontal recess region. One must be mindful, however, laterally of the lamina papyracea, because when using powered instruments, one must be cautious always of the face of the microdebrider. It must always be under vision so that it does not injure the superior portion of lamina papyracea. That can lead to inadvertent orbital trauma, as well as can lead to protrusion of orbital fat inside the frontal recess, which is sure to cause any disruption of the work inside the frontal recess, as well as causing possible stenosis of the area. Now, with the frontal sinus curette, we can gently palpate more cells as we remove them. And now, since some ethmoidal septations were remaining, as we had seen in the preoperative CT scans, it is prudent to remove all those septations as much as possible flush to the roof of the nasal cavity and the roof of the ethmoids, to be able to achieve a clear access and remove the amount of redundant mucosa and bone that could lead to recurrence of polyps. So here we use a Heberhold cranial true cutting forceps to remove the ethmoidal septations. Before each bite, we palpate as to what extent our instrument goes, and then we resect one by one. And this is quite handy in removing most of the ethmoidal septations flush to the skull base, and to be able to make sure that the amount of excess bone and mucosa that could lead to polyp formation again in the ethmoids is reduced to minimum. Now we use a curved frontal sinus suction, a thin one, to guide our way inside the frontal recess. Of course, one must be mindful never to force your way inside, because that can lead to false tracks and then it would be very difficult to access furthermore. As we can see, now the frontal recess seems to be widely open and we need to identify the cells which were blocking our way inside the frontal sinus. Inside this complex anatomy, the navigation probe is a lot of help in terms of identifying the exact cell that you are in, because since the height of the frontal bular cell is similar to this height of the frontal sinus, often a blind instrumentation would not be able to identify if you are really in the frontal sinus per se or the frontal bular cell. Also, when these kind of cells or altered anatomy are encountered, one must increase the exposure overall inferiorly to be able to access all these cells comfortably. So now we resort to an articulated frontal sinus punch to clear some more bone of the beak of the frontal beak, and to create more space for ourselves anteriorly, that we can identify the all the cells inside the frontal recess area that go high up inside the frontal sinus actual, to be able to remove them conclusively under vision. One must be cautious in using this instrument because it often slips. So having a good engagement of the frontal beak region is very important while using the articulated punch or so-called cobra punch to be able to clear the bone. Otherwise, it just tends to slip and not cut through any bone. So as we clear, now we are able to see the view of the frontal beak, which is a very important landmark. Now, as we get a view inside the frontal sinus, we still have to conclusively see if the cell that was blocking the sinus per se, the bular cell, has it been removed or does it still remain? So for that, once again, we resort to using a frontal sinus curette to fracture any cell that still remains inside the frontal sinus and to be able to get a clear view of the whole sinus itself. As we see here, if you see carefully, this is the frontal bular cell that we are now fracturing. So one can fracture it laterally to be very safe, but sometimes if it is a little loose, one can fracture it both ways and then try to remove it using a giraffe forceps. As you see here, we would still like to increase slightly the exposure by trimming some more of the frontal beak region to be able to get even a better view of this cell so that we can remove it conclusively. So further removal of this some bone from the beak or frontal bone or frontal beak area gives us a better view of this isolated frontal bular cell that was blocking the frontal sinus. As we can see here, this is the wall of this cell, and one can hook around this cell and go inside the frontal sinus region as well. So as you can see, probably it's lying loose, but still it has to be removed to be able to get a clear view of the frontal sinus. So here we use a curette to be able to identify clearly. Like you see here, both the walls of this cell are now clearly visible. And you can see the walls of this cell that was occluding the frontal sinus per se on the left side. And this has been completely loosened, but still is attached a little bit towards at the posterior wall of the frontal sinus. And this kind of access and vision inside the frontal sinus is only possible because of the removal of some portion of the frontal beak. And this is short of actual drilling, which would be required in some more cases if the pathology were to be more lateral to the mid-pupillary line. Once this cell has been loosened, fractured, we can resort to a giraffe forceps, which is appropriately angled, to grasp the wall of this suprabular cell and clear this off to create a straightforward opening inside the frontal sinus. As you can see, the inferior 2/3 of the party wall between the bular cell and the frontal sinus have been removed, with a slight superior 1/3 still remaining. And sometimes it becomes a little difficult without drilling the bone of the frontal beak to get the instruments that high up. So as long as we are sure that our access to the frontal sinus is adequate, that 1/3 of the bone sometimes could be left as well, because then removed in an attempt to remove that, one mustn't really cause more trauma collaterally towards the septum and the lateral nasal wall, because then that could lead to scars and adhesions and eventual synecdoche formation. So now we come to the right side of the patient. And once again, we repeat what we did on the left side by opening the sphenoid os widely, initially the soft tissue by the microdebrider, and later on by the bone punches to create a wide sphenoid opening. So we normally use the bone punch because of it's a very robust instrument. Otherwise, for more fine work, one could even use a straight mushroom, but mostly it just breaks quite easily when encountering tough bone. So we generally use the upward facing straight bone punch, and you can also turn it downwards and laterally to be able to conclusively clear more bone of the frontal sinus, of the sphenoid sinus walls. Once the sphenoid sinus ostium has been sufficiently widened for a good access intraoperatively as well as for postoperative irrigation, one can see even the lateral recess exposed. We resort to again using a frontal sinus curette to clear the party wall from the anterior ethmoids and to be opening the area of the frontal recess and sinus, which again was a prime concern in this patient. So to summarize, the most important parts that we had to do as a revision in this kind of patient were basically opening the sphenoid widely again, removing the ethmoidal septations to reduce the chance of recurrence, and open the frontal sinuses on both sides widely by removing all the cells that were causing restriction or crowding of the frontal sinus drainage outflow. In revision surgery, however, scarring and loss of previous landmarks and scar tissue can often lead to illusions, and there is obviously a higher propensity for collateral damage. So as we see here, we are trying to again dissect from posterior to anterior in the frontal recess region, so that we adhere to safety norms and do not penetrate the thin bone of the roof of nose, that is the cribriform plate. And once we initially do not use the shaver in the starting part because we want to fracture the thin bone, and we resort to the shaver blade only once we feel that we have fractured a lot of thin septations, which can be then taken down by a shaver blade. Using a shaver blade on hard, thick bone, unfractured bone often would lead to just bleeding and add to the surgical frustration in this very narrow region. So once again, we resort to removing some portion of the anterior wall of the agar nasi, and that is towards the attachment of the middle turbinate, the axilla of it, to create a better viewing angle inside the frontal recess region. Otherwise, this step would require possibly angled scopes like 70-degree scopes to be able to visualize. While that is okay, but having some more access even improves the overall trajectory of the irrigation in the post-operative period, because the more bone anteriorly is removed, the easier it is for irrigation fluid to go towards the frontal sinus region. So once again, post-dissection of the septations inside the frontal recess, we're using a thin suction to sort of gradually and progressively increase our access towards the frontal recess region, and thus the sinus. Now again, we palpate and remove the ethmoidal septations, working our way from posterior to anterior, thus clearing almost all septations in the posterior, followed by anterior ethmoid region. Once it is felt that there is a lot of loose mucosa or loose bone inside the frontal recess region or the anterior ethmoids, then some amount of microdebrider can be used in this region to clear off the redundant bone and the mucosa. For rest of it, an olive tip suction, a thin olive tip suction, or a frontal sinus suction curette often works very well. However, the frontal sinus suction curette is a sharp instrument and can sometimes lead to unnecessarily penetration of the skull base. So whenever in doubt, using an olive tipped instrument which is gently curved is actually a much safer option. Once we have cleared some amount of ethmoidal septations, then we again work our way from posterior to anterior inside the frontal recess and the frontal sinus region to remove all the septations, remove all bone and the type 3 cell, type 2 or type 3 cell configuration that we had seen in the preoperative CT. Once all the bone and the mucosa has been made loose, then one can use a 40-degree angled shaver blade to clear some excess mucosa and tissue from this region. Once again, making sure that the shaver blade does not penetrate the orbit. We are just using here the frontal sinus navigation suction to locate our way inside the complex anatomy here. And we can see how the frontal sinus has been opened, and some excess bone, excess mucosa here can be gradually removed using a giraffe forceps. Once that is done, we see that the frontal sinus has been opened, though some excess mucosa is there that still needs to be trimmed a little. Why? Because we can see the frontal beak and how our instrument is going just behind the frontal beak and has a very clear lateral trajectory from medial to lateral to expose and make sure that the frontal sinus has been widely and reasonably opened. Excess bony chips or loose bony chips should be removed from this area, because then they would otherwise lead to formation of granulation tissue, which would later on lead to scar formation. And some excess polyps can also be cleared from this region. This is the view inside the erstwhile opened left-sided frontal sinus, where one can see the slight part of the superior wall of the bular cell still there, but most of it being cleared, and with the frontal sinus now opening widely medial to this cell, the party wall of which has been removed. One can see how widely the frontal sinus has been opened. We can still make a small attempt to be able to see if we can clear the superiormost part of the party wall that separates the bular cell from the frontal sinus. One must be careful not to overshoot or remove the mucosa from the frontal sinus or demucosalize it, because then that would lead to scarring. But a little bit of bone, if it can be removed as such, then that would just open the frontal sinus completely. And thus reducing the chances of recurrence in these kind of patients for polyp formation. Still, some bone from the frontal beak can be removed, and while this may not be compulsory, however, the straighter the trajectory towards the frontal sinus, the better are the outcomes from nasal irrigation in the post-operative period, thus ensuring lesser recurrence rates in these patients of polyps, which essentially involve the anterior ethmoids and the frontal sinus. So you can see how the entire frontal bular cell has now been cleared, and our access inside the frontal sinus in this revision situation is complete.